Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and today I have David Scholes with me. David is the manager of the TMC Sleep Diagnostics Lab, and he is here to continue on with our topic about sleep. We've already talked about medications and maybe how to train your brain to sleep, but here he's going to talk to you about, are you having trouble sleeping, and some techniques and things that you might want to look at. So he has a great presentation. You could be watching us today on our TMC for Seniors Facebook page or on our YouTube page. Please feel free to leave any questions in the comment areas, and we will get to those when he finishes his presentation. So welcome, David.
Hello. Welcome, everybody. It's good to see everybody, although I can't see your faces.
So go ahead, David. You can go ahead and start with your topic.
Very good. Okay. My name is David Scholes. I'm the manager of TMC Sleep Lab. I'm going to talk to you a little bit about the basics of sleep and really what sleep is and kind of how it incorporates in terms of a healthy lifestyle. So there's 5 stages of sleep, and the first stage of sleep is drowsiness. It's the transition from sleep to wakefulness to sleep. And that's kind of like the boring part of a movie when you're falling asleep. And then stage 2 sleep is where you're going to spend a majority of your time in the 8-hour window that you're trying to sleep. And sleeping is stage 2. It's restful sleep. Stage 3 and 4 is considered deep or slow wave sleep. If you've ever witnessed someone or yourself talking during your sleep or sleepwalking, that occurs during this stage of sleep. And then finally, there's stage 5 or REM sleep, and that's dream sleep. That's where your dreams present themselves. And it's the only 2 muscles in your body that work during dream sleep are your diaphragm for breathing and then your eyes. And that's why a lot of people notice a sleeping member that their eyes are moving and they're kind of tracking during the dream. So that's an interesting phenomenon that only 2 muscles in your body work in dream sleep, and that's your diaphragm and your eyes. So the patterns of sleep stage with age, and that's some of the topics that we're going to talk about a little bit later, is newborns, their sleep patterns mature and their brainwave patterns mature, and they kind of evolve into the 5 stages of sleep. So next slide. Circadian rhythms. Some of you may have heard of circadian rhythms. It's the natural cycle of which you go through when your body and your brain tells you to be awake and when you need to be asleep. And the hypothalamus controls that biological clock or that circadian rhythm. And it's important to be awake during daylight hours and then asleep during nighttime hours. It is possible to flip your circadian rhythm, especially for people that have chronically worked on night shift, and be able to have a different circadian rhythm out of context from the daylight and nighttime hours. Next slide. Important factors with the circadian rhythm is that the clock is stimulated by daylight and activity. And I emphasize that a few times already, is because it's important that your activity levels stay at your baseline or as high as it can be. You stay active during the day, and that will convince yourself, your body, when it's time to sleep, to lay down and go to bed. And during the nighttime hours, you start to produce melatonin when the sun goes down, and your body's trying to convince yourself it's time to sleep. And it's important that you listen to your body in that time and try to keep those circadian rhythms and those cycles and those in tune. Disruption of the circadian rhythm can definitely happen if you travel a lot, or like I said, you mentioned shift workers. If you stay up in the middle of the night, maybe because you're having a gathering or because something's happening, you can definitely increase your ability to fall asleep if you can keep a normal circadian rhythm cycle, but you can also aggravate it and it'd be difficult in those times. So we want to try to keep those wake times and bed times fairly close throughout the day, throughout the week. Next slide. So some tidbits about sleep cycles and transitioning of stages of sleep. I usually try to tell people that it's very important So the sleep cycle, your brain goes through, your body goes through about those 5 stages of sleep every 90 minutes of uninterrupted sleep. That's why it's important to maximize your comfort level when you're trying to sleep. I speak to my patients about the difference between rest and sleep, and comfort kind of goes along with rest. Make sure that you've toileted probably prior to bedtime. The temperature of the room is good, and that everything's set up for you to have the most restful sleep that you can, so that it's not interrupted. Maybe the noise level is an act. So there's no real magic number for the amount of sleep. I get that question a lot. How much sleep do I need, David? And literature states that the average person needs about 7.5 to 9 hours of sleep, just depending. The main thing that I want to talk about on this slide is sleep depth. So if you have something and you only get 4 hours of sleep, for example, then it kind of contributes to your sleep debt. And you don't naturally just make up that sleep by going to bed or waking up later, for example. So if you were to go to bed and only get the 4 hours of sleep on, say, a Monday, and then Tuesday you just said, well, I'll sleep till 1 or 2 in the afternoon, your body and your brain and the restfulness of your sleep is not going to erase that all in one day. You're better off going to bed a little earlier and paying back that sleep debt over time. One night of sleep deprivation takes the average person 3 days to recover from one night of sleep deprivation. And that's not purposeful. Sometimes people go to bed with every intent to fall asleep and get a good restful sleep, but they're come 2, 3 o'clock in the morning, they still haven't fallen asleep. And then I encourage my patients to go to bed earlier and try to repay that sleep debt throughout the week, instead of maybe if you're working, then a lot of you hear this, oh, I'll just make it up on the weekend. As I said earlier, 3 days, it's not enough to make up that sleep debt just over the weekend. You're better off changing your cycle, going to bed a little bit earlier to make that up. Next slide. Artificial sleep. So you've probably heard a lot about artificial sleep, and Ambien is real popular, and different things. And as I talk about this slide, I'm not going to discourage it. Talk to your physician. They're definitely appropriate, but I always increase the knowledge around this topic and the severity of this topic. I had a friend who was having some trouble sleeping, and he was using a medication that to sleep. And then he brought it to my attention. He said, David, I having some funny things happen. And I said, what do you mean? And he goes, well, you know how I have trouble sleeping? And I said, yes. And he said, well, I took this medicine, and I got in my car to go to work the next day, and I saw some receipts that I went to Burger King, but I don't remember going to Burger King. And the time on the Burger King receipt was like 3 o'clock in the morning. And I said, you really need to bring that attention to your doctor, and maybe you need a different sleep aid. Maybe you need something different. But that's definitely a behavior, and some of the medications that are on there to help you sleep, there is a documentation of some bizarre behaviors, is what we'll call it. Whereas sleep driving, sleep eating, people technically being asleep, not remembering, and being able to carry out those activities. And that's obviously concerning. That same friend didn't take my advice, and he continued to do what he did. And then a few months later, he said, yeah, something really weird happened this time. And I said, oh, yeah, what happened? And he says, I had pre-purchased some kitchen cabinets. His plan was to redo his kitchen. And he woke up in the morning and came out to all of the cabinets being taken off of the kitchen walls, and all the new cabinets being hung up, and that he didn't know where the old cabinets had been disposed of, but he assumed that he had put them in the truck and then disposed of them somewhere, and he doesn't remember it at all. And so I caution you about sleep aids, and I am not anti sleep medications, but if those bizarre behaviors happen, it is crucial that you bring those to attention of your physician, And a lot of people are hesitant because they think that they need to sleep and the sleep is important, and they don't want to mention anything because they don't want to be that aid to be taken away, where maybe you just need a different type of sleep aid temporarily until we figure out what's wrong. Again, he didn't listen to me, and then he ran his car into a telephone pole, and he survived, but he was injured from the accident, and that's what finally woke him up that that was not the particular sleep aid for him. One of the more common or most popular that we heard about was when Michael Jackson was with us. He was taking sleep aids. Artificial sleep is what we're calling it. And he, at the end, people closest to him talked about bizarre, dangerous behaviors. He wasn't himself. It was odd. And after he had passed, they come to find out that he's the longest documented patient to only have artificial sleep was for 90 days. He had been medicated every day for sleep for 90 days. And that behavior that he presented with to the people closest to him is kind of what your body goes through when it's only being dealt artificial sleep. So in summary, artificial sleep or sleep aids are to be temporary until we figure out what's going on. You may need an in-lab study, like you come to one of my sleep labs and we study you and figure out what the cause is. It could be a home sleep study where we send you home with a piece of equipment and then we find out what's going on, or a combination of both. And that's where your doctor can prescribe these sleep aids temporarily until we find the cause, and then we treat the cause. Next slide. Sleep hygiene, and I'm not talking about brushing your teeth before bed. Basically, sleep hygiene in the world of sleep and in my sleep lab, we talk about certain behaviors and certain routines that we go through that is important to get the best quality sleep that you can. And some of this people don't like to hear, but television negatively affects the depths of your sleep. If anybody's fallen asleep with the TV on, at different parts of the program, the volume increases and decreased, and then the flickering of the light. Well, the way your brain reacts to that is what's called a K complex, and it's an awakening, and it'll keep you from transitioning to those deeper stages of sleep, and you'll only stay in those lighter stages of sleep, unbeknownst to you that you're not able to transition to those deeper, more restful parts of the cycle that I talked about earlier, because the noise of the TV just keeps you at that. So I suggest to my patients, because I do realize that TV, sometimes the noise is a comfort, especially if you don't have a bed partner, that you set the sleep mode where it'll be on for 20 minutes and then it'll shut itself off, and then you'll be able to cycle through the stages of sleep uninterrupted and without those awakenings that I spoke about. Eating negatively or eating in bed can negatively affect the time it takes to fall asleep. You're confusing your brain because you're stimulating it. And am I supposed to be awake? That's a behavior that's usually when we're awake, and it could. And then parallel to run to that is acid reflux can definitely play in the comfort. And so we definitely want to try to give you your bedtime eating or your nighttime meal some time to calm down before you go to bed. Soothing music or white noise in a fan is one of those examples. Definitely can block out some of those unwarranted noises, maybe from other rooms, or if you live on a busy street, traffic. Those are all good things to have, and I encourage those to help with the depth of your sleep and being able to transition to those stages of sleep. Keeping a regular bedtime and wake time can definitely improve the quality and your sleep efficiency. The most consistent thing you'll hear from me today is a normal, regular bedtime and wake time. Try to pick whatever your lifestyle is. What can I keep? What bedtime can I keep consistently, and what wake time can I keep consistently, whether it's the weekend or the weekday. I have a story about that. My dad came to the sleep lab. He was having trouble sleeping and he has sleep apnea. And he came to me and he said, boy, I'm 46 years old. He still calls me boy. And he says, boy, I'm having trouble sleeping. And I said, yeah, Pop. I said, maybe you should have a sleep study. And he goes, no. And I said, well, what time do you go to bed? And he goes, well, whatever time I want. I'm retired. And I said, really? And he goes, yeah. And I go, well, he goes, well, I just go to bed late, or, if your mom wants to watch a movie, or if I read a book or something. So I don't keep, I just go to bed whenever I want. I said, is sometimes that after midnight? And he goes, oh yeah, sometimes I'll get in a good book and I'll just read until 1 or 2. So, well, what time do you wake up? And he goes, well, whatever time I wake up. So we come to find out with a diary, and that's what I'm getting at with, is it's a good time to track your bedtime and wake time. If you really want to be an advocate for your own sleep, control what you can control. Take a diary. Try to keep that normal bedtime, wake time. And like I said, try to pick realistic goals where you could be able to meet those 90% of the time, or maybe even 100% of the time, and advocate for that, and position things in your life so that you're able to keep those wake times. That's probably one of the biggest things that we see in the sleep lab, is people are changing their bedtime, wake time just daily, nightly. And so the other is obvious, but it makes mention, is limiting your meals and your caffeine 3 to 4 hours prior to bedtime. Some people can drink a pot of coffee and still go to bed, and some people can't. And some people can just have a half a soda, and it contribute, that caffeine can really stimulate them and cause for what we call a delayed sleep onset. So it can take several hours for them to fall asleep. The temperature of the room can definitely affect sleep, as naps during the day. So we always say that there was a big push a few years ago about the benefits of naps during the day. And I'm not against naps, but you want to limit those naps to less than 20 minutes. And because of the cycle that I talked about earlier, if you sleep too long and you start to get in those deeper stages of sleep, then sometimes your brain gets confused. And then when you actually go to bed for nocturnal at nighttime, then it's like, okay, what stage of sleep am I supposed to be in? And it keeps you in those lighter stages of sleep, which you're not going to get into that more restful sleep. Next slide. So aging and sleep, as we did a lot of the literature supports, there's a lot of literature out there. And Harvard did a really good study a few years back that talks about the ages and what really happens for people that maybe in their younger years didn't have a problem sleeping, and now it presents that they're having trouble. So total sleep time decreases until about the age of 80, and then it starts to increase slightly. So it's pretty consistent across the board. The time in bed increases, but with less time spent asleep. So it's going to take you a little bit longer to get to bed, to fall asleep, and to get comfortable. And so that's a realistic expectation, that as we get older, it's going to take a little bit longer to fall asleep. The time getting to sleep takes longer, as I just mentioned, and then your wake up during your sleep, your awakenings while you're sleeping, is going to increase with age. That's just a normal phenomenon that we've noticed. And some of it is dealt with toileting, having to get up more often for that reason. Some of it leads into pain. Back pain is a big thing, hip pain, that might cause you to wake up a little bit. And one of the things that I'm seeing in the sleep lab is someone that previously slept pretty well is getting actually frustrated, but now they're having problems. So I think a realistic expectation of that your sleep might change a little bit, might ease some of that frustration. And then when it gets to the point where maybe you're falling asleep during the day, or you're not able to complete activities that bring you enjoyment, then maybe go talk to your physician and say, something's going on. Maybe we need to rule out that I don't have a sleep disorder that we could address, because this is a little bit more than just getting older. Next slide. So this is just a nice little graph that kind of talks about, I spoke a little bit earlier about sleep latency. WASO is an acronym for wake after sleep onset. So you can see the ages at the bottom. You have 10 years old all the way up to 85. And then the stages of sleep, stage 1, stage 2, they're pretty consistent from the time you're a child, from the time you're 85. And then as you start to get into slow wave sleep as SWS, it's increased when you're a child, and it starts to slowly decrease over time as we get older. The same with REM sleep, and that's that dream sleep that I talk about. And so a lot of patients will tell me, I don't dream anymore, David. And I'll tell you right now, you're not supposed to remember your dreams. If you go through and cycle through the normal stages of sleep, you'll probably never remember your dreams. If you have an awakening in the middle of your dream, say the alarm clock goes off. Well, nobody has alarm clocks anymore. If your phone goes off and wakes you up for work, or if there was an accident out front and the noise woke you up or startled you, or maybe your dog barked, and you happened to be in REM sleep, dream sleep, then you would remember that dream. So obviously, if there's some underlying sleep disorder and you're having maybe sleep apnea or snore arousals, and you're waking up in the middle of those, then you will remember your dreams. But if your sleep is consistent and you're cycling through those stages of sleep, then you really shouldn't remember your dream. However, with age, the amount of time spent in dream sleep does decrease. So that's noteworthy. Okay. As you start to see for newborns and everything, it takes a little bit of time for them to fall asleep. As anybody that's been a parent or known a small child, it takes a little bit longer for them to fall asleep, and then it dropped a little bit, and then it kind of is more consistent from about 35 to 85 that the sleep latency should stay about the same. Okay. Next slide. And this just highlights kind of just bringing attention to what I just talked about the decrease in REM sleep. Click again. And then the increased wake after sleep onset. You're going to have some periods of time where you're need to fall back asleep as you start to get older, and try not to be frustrated. Just concentrate on making yourself comfortable and try to go back to bed. Click again. Again. And the decrease in slow wave sleep, and really there's no change in stage 1 and 2, which I already mentioned. Click again. Okay, and again. There we go. And this is just looking at it from a different graph, basically everything we just talked about. But the awakenings, I'm going to talk a lot about that, awakenings, because the sleep efficiency and the quality of your sleep really is if you're able to cycle to those deeper stages of sleep. So one example that I like to bring in this slide is pets. I get a lot of questions about, I had this particular patient say, I'm having some trouble sleeping. And I said, okay, well, can you describe kind of your sleeping situation? He said, well, I have a cat, and then I don't have a bed partner, but the cat sleeps on my head, or up on my pillow on my head. And I said, is that comfortable for you? And he said, well, the cat seems to like it. And I'm like, well, does it wake you up? And he goes, well, sometimes. And I said, okay, well, I understand that the pets bring companionship and comfort, especially when you don't have a bed partner, which is important. But when their sleep and their movement can awaken you in the middle of the night, that is a factor on your sleep efficiency and how well you're sleeping. The other parallel that I run to this is when you have to let the dog out to go toilet, and they'll scratch at the door, or you'll have to get up, and that's more than once or twice. That can definitely be a factor. And I am not anti-pets. Pets bring a lot of companionship, like I said earlier, and security, and especially for some patients. And I'm not saying but just be aware that if your sleep's not good, then maybe set a diary, a little thing. Okay. Maybe your puppy sleeps with you Monday through Wednesday, and you track how well you think you slept, and then maybe put him out in another room, and then you sleep the other days, and to make your own decision if you think it's a factor. Next slide. And I spoke about this. Older people have an unrealistic expectation of sleep. A lot of the aging population goes back to how they've always slept. And that was the conversation I talked about to my dad. I mean, my dad could sleep on a picnic table, and up until he was 50, 60 years old. And then about 65, he really started to have trouble sleeping. So having a realistic expectation that your sleep is going to change a little bit makes him a little bit anxious, and others a little bit less anxious, that they're short, your sleep's a little bit shorter, and that doesn't mean that it's not quality sleep. Next slide. This is just another, we talked about, or you heard me talk about sleep efficiency, a percentage of time that you're in bed that you're actually asleep. And so this just gives an age perspective that it does decrease a little bit, and that's that wake after sleep onset, that's a normal phenomenon. It doesn't necessarily mean that anything's wrong, but that would be present itself. That so being in bed longer will obviously increase your time of sleep. Next slide. As we get in now is sleep disorders, and insomnia is one of the more common ones that you hear about in the community. Insomnia is actually a symptom. It's not really a diagnosis. Usually something causes the insomnia. So sleep apnea is one that's become very popular in many age groups. So we're seeing changes in patients' breathing patterns in childhood, and them having sleep apnea. And then we're seeing it in other populations. It used to be when I first got into sleep medicine that the typical patient was over the age of 40, male, with slightly overweight that had sleep apnea. And now we're seeing that little grandmas weighing 95 pounds with small airways that can still have sleep apnea, and that restriction to their airway is what's causing the sleep apnea. Periodic limb movements is common. As we get older, you're more prone to having things like neuropathy, tingling, numbness, nerve damage in your feet and legs, and that can cause movements of your legs, and that can cause awakenings. There's medications to treat those. Restless leg syndrome and periodic leg movements are essentially the same thing. The only difference is restless leg happens when you're awake. And if you've seen somebody shake their feet while they're watching TV, they just get the creepy crawlies in their legs and they just feel like they need to move them, or they stand up and walk around. That's restless leg syndrome. Periodic limb movement happens when you're already asleep, and you're moving your feet in your subconscious and you're not really aware of it, but it's limiting your ability to transition to those deeper stages of sleep. REM behavior disorder is definitely something, but it's a rare sleep disorder. It's you see it a lot in veterans and wartime people that went through a traumatic event where they act out that event during their sleep. We've studied patients that come in that were in the war that would crawl out of bed and get on the floor, and they were technically asleep. And there's a way to treat that as well with medication. Next slide. Sleep disorder breathing is what I'm going to speak on. And it's basically a blockage of your airway. So you can see in the picture, the purple is the flow of air there, and the tissues can start to be relaxed when you fall asleep and can actually obstruct that airway and not allow you. Your brain will naturally wake you up. It is very alarming for the patient. They feel like sometimes if they go to sleep and they have an apneic event that they won't start breathing again. When your oxygen level drops, and your brain will alert you to wake up, and then your airway will then open again. But if you do this several times throughout the night, you're not going to get restful sleep. You're going to be very tired. But now the literature supports that now it can be a contributing factor to, say, heart problems, heart conditions, heart attacks, stroke, high blood pressure, even diabetes. Whereas if you take it like an exercise where your blood sugars are moving, when you're breathing and trying to catch your breath so often, and this is happening 60 times an hour, then your blood sugar is going to be all out of whack, and that sometimes can lead to the diabetes, as I mentioned. Next slide. This is an example of what we do here at TMC in the sleep lab. This is a picture of what my techs look at when you're sleeping in the lab. This is a sleep study. So the awakenings and those stages of sleep that I talked about, that's the green circle, and that's an awakening. So they were asleep prior, and then something happened, and in this case, in this example, they stopped breathing, which is the red circle. And so you see the nice rhythmic breathing patterns to the left of the circle, and and now it's stopped. And that's how we know that there's a problem. And then your brain, the green circle, alerts, and then you go into these lighter stages of sleep or wake up completely. And that's what we're trying to eliminate at the sleep lab, to see if you do have a sleep disorder, if you have a sleep apnea or obstructive sleep apnea, that we can treat it. And then the blue arrows down, those are snores. So it's possible, and I do get that question a lot. I snore pretty loud. Is that abnormal? You can see that the snoring is pretty prevalent. It's that black line right there. But there's no changes in the breathing. The flow is continuing normally. So the only two things that I could say about snoring is if does your oxygen drop when you're snoring, and does it wake you up? And the most common answer I get is, well, it wakes my wife up and then she wakes me up. And so then that's a little different. So, I mean, but technically it's not abnormal. Now, people that snore can also have apnea, and that's the red circle. So that's what we want to address. And how often does that happen? So back to the red circle, and certain amount of apnea or changes in your breathing when you sleep is normal. We want to keep that to 5 or less an hour. If that creeps up to around 15 events an hour, you meet criteria to be treated with what's called CPAP or BiPAP. And CPAP stands for continuous positive airway pressure. It's a mask that fits over your nose or mouth, or just your nose. And it provides pressure to keep your airway open so that you're able to breathe freely and without waking up. Next slide. Okay, PLMs and aging, the leg movements, and we talked about, where I talked about the stages and the creepy crawly feelings. Definitely as we start to age, and all of us are aging, things can kind of creep up, like Parkinson, maybe kidney problems, renal disease, diabetes, spinal problems with your back can definitely increase this disorder, where you're having to discomfort in your legs and you really don't know why, and you got to move them or shake, and that's definitely treatable. You need to bring it to your attention to your doctor. And there are certain medications that can exacerbate the problem, and alcohol can definitely increase them. So we want to limit that as well. Next slide. I spoke a little bit about the REM behavior disorder, the veterans, people that go through traumatic events, life events that they need. And we definitely encourage bringing those to the attention, because those are actual physical activity where people are unlocking doors and walking outside and could possibly be in harm's way. So I use this side to educate people. If maybe it's not you, but you heard it, and then maybe one of your loved ones or family member or friend of describing certain things. Hey, I listened to a guy that was talking about that. You might want to bring that to your attention to your doctor, because that's not normal. So that's why we talk about REM behavior disorder, that acting out. Remember, I talked about how REM being the only two muscles in REM sleep are your work or your diaphragm and your eyes. So when you're up moving around, there's something that's just needs to be addressed. Next slide. So the consequences of poor sleep and daytime sleepiness, especially in the aging population, decrease in attention, memory is probably a big thing. We hear it a lot. Oh, it's, are you having trouble with your memory? Well, yeah, I'm getting older, and some of it's due to quality sleep. It's definitely when you're sleep deprived and you're not sleeping as well at any age, you can have problems with memory. Increased depression. I know it's a difficult time right now, especially with COVID-19 hitting all age groups and facets, but it can increase your depression when you're not sleeping well. Accidents, you can have problems with balance and falls, especially if you're using other medications for artificial sleep, like sleep aids or sedatives, and then you're already sleep deprived, and that can put you at susceptibility for accidents. Motor vehicle accidents, that's the acronym MVAs. Definitely your attention. is maybe not as sharp when you're being sleep deprived. So we definitely want to address that. We don't want to tolerate it. I feel like a lot of people in the community at all age groups are tolerating the poor sleep, and it just makes them more prone to unfortunate events. And then the bottom bullet is increased hypertension, high blood pressure, and morbidity and mortality with obstructive sleep apnea. So if you have a bed partner and they're telling you that you're snoring or that you stop breathing at night, that is definitely something you want to bring up to the attention of your physician and say, something's going on. I don't think I'm sleeping right. Can I get a sleep study at TMC? And we can talk about that. And I take this moment to really, if you have a strong relationship with, say, a physician, a PCP, or maybe you have a specialist that you really trust, anyone can order a sleep study. You don't have to see a sleep specialist. You're able to. There are a few in town that they exclusively just see patients that are having sleep problems. But I always encourage patients that we've educated the community and the physicians to be able to order sleep studies. And my doctors are the board certified sleep specialists, and they will give recommendations to your doctor. Because I think some patients are a little hesitant to get it looked at because they don't want another doctor. It's just another set of appointments. So I take this moment to just say, if you have a good relationship with your physician and you trust the care that they're providing in other facets of your regime, then just ask them if there's any way you could have your sleep looked at. If any of what we've talked about today kind of strikes a bell, or you're like, yeah, that kind of sounds familiar. Sleep deprivation can lead to some pretty serious health problems. Like I spoke about earlier, it's a lot of patients think it's just an inconvenience. So I didn't sleep very well, and it can lead to some high incidence with stroke, diabetes, heart failure. Those are big things that sometimes people don't recover from. So we want to address and get you the best quality sleep we can, so we can get you off. We've usually, one of the signs of when you have really uncontrolled hypertension or high blood pressure, and you're on 2 or 3 different medications and you're just not making a dent, is a lot at that point the physicians will start to order a sleep study. And what's coming out is that they have sleep apnea, and that's why they can't control their blood pressure during the day. And so we treat the sleep apnea, and some patients are able to come off their high blood pressure medicine. Next slide. Bedtime. This is a checklist that we use in the sleep lab, and that we try to teach the patients or anybody that's wanting to improve their sleep. Is just, is the temperature of the room okay? Is your pain control okay? Did you take your pain medicine? Maybe you're not in pain at that moment, but if you're able to use your medication, then go ahead and use it for pain control so you don't wake up in the middle of the night. Are you going to bed on time? If you are a CPAP patient, make every attempt to use it. It makes a difference. Is the television off, or is it set to go to the sleep mode? Are your pets in the bed, or are they in the room? Do you want them there? Noise control. We in the sleep lab at TMC, we have white noise. It can sound like the beach. It can sound like wind. We have these noise machines that really block out. They're very effective, and the patients like them. You can get them on Amazon pretty cheap for the house, and for your current sleeping environment. Are you toileting prior to bedtime? That's definitely something that can interrupt your sleep. And is the lighting reduced? Is it dark? Do you want it to be dark? Some people have, like I said, had a traumatic event or a life event that makes it, and maybe having a little light, or if you have a bathroom close to the bedroom, maybe cracking that door a little bit gives you some reassurance, and then that would help the comfort level and the confidence level, so you can feel like you can fall asleep. Next slide. Daytime. Did you wake up on time? Were you exposed to sunlight or other light sources? Did you take a walk? Did you go get the mail? Are you active as you could be? Are you limiting your naps, if you do take a nap, to 20, 30 minutes? Are you trying to schedule those naps so they're not so late in the afternoon that would interrupt your nocturnal or nighttime bedtime? Did you decrease or eliminate alcohol right before bed or in the evening? Did you make every attempt to do those? So those are the kind of the high points that I like to mention. Next slide. So basically, in conclusion, we're talking about that sleep cycle and the rhythms and trying to keep you asleep essentially instead of that interrupted sleep, and realizing the factors in your life and in your environment, your sleep environment, that could possibly, even unbeknownst to you, wake you up and interrupt your sleep. So if you can control that, then that might be all you need, is to improve your quality of sleep. And then if it's a little bit more severe, and we talked about the apnea and other things, then you can come into a sleep lab like a TMC and have it addressed and looked at and see if there is something. One of the things I tell patients is having a sleep study at TMC is not supposed to be scary. It's pretty easy. I mean, yes, there's monitors and electrodes that need to go on you to monitor different aspects of your sleep, and we monitor for you in another room, but it's a private room. It's dark, it's quiet. If you need to get up, the tech comes in and helps you to the bathroom. We can put a bedside commode if you don't ambulate well, so you don't even have to. You can get up and use the bathroom right there in your room, and address those issues. It doesn't have to be scary. And one of the things that I do tell them is, like, some patients don't want, oh, it's nothing, I don't want to waste your time, I'm sure it's nothing. Well, at least it'll give you peace of mind, that you don't have a sleep disorder, or you don't have sleep apnea, and then that maybe you just need some hygiene or some routine changes in your sleep environment to help you sleep better. Next slide. Questions?
So thank you so much, David. So I do have a couple of questions that came in.
Very good.
One is about insurance.
Okay.
Is it covered? I mean,
Yeah.
like most insurances, or is it something that isn't covered?
That's a good question, actually, and definitely, especially nowadays, but anytime, yeah, your financial involvement is important. So yes, it is covered, and more insurance companies are realizing that years ago, when it wasn't so easily covered, that it was leading into those more expensive procedures, more expensive chronic treatment. So now they're definitely making it basically a covered expense. And most patients is covered by Medicare, definitely. Doesn't even require an authorization. Some payers do require some documentation that your your physician or my sleep lab can provide. So
Great.
Yes.
Thank you. And then I had somebody ask about the difference maybe between sleeping in the winter as opposed to the summer. When it gets darker earlier, do you find that folks tend to go to sleep earlier, or not necessarily? Should they continue to stay on their same?
Great question. Yeah, it's a great question. So there's not a lot of literature, but it does happen. I would say yes, we would want to try to keep you on your same sleep pattern. And even though it's a sleep, so basically, if you're going to need to close the curtains because the sun comes up a little bit earlier, that's definitely you want to do that before you go to bed. I know that my bed partner, she has a sleep mask because we got a lot of windows in there, so I can tell that when she gets to the restroom and then she comes back, then she puts the sleep mask on, and she's good to go even if the sun comes in the window. So those are definitely factors, but I would say keep the same routine even in the stage or time of the year. So
great. And what about, can you just walk us through a little bit more about what happens when you have a sleep study? Because I'm sure people don't really know, or if you've never experienced that, what is that like?
I think the unknown is anxious for the patient. So I strongly encourage, if you have to or you choose to have a sleep study, give me a call. Call one of my techs. We'd be happy to walk you through prior to that day to try to decrease some of the anxiousness. But yes, so basically you'll come in to the lobby, and they're going to ask you some questions, and they're going to give you some questionnaires that's going to talk about your normal sleep and some of your history of sleep, and you're going to fill that out. And then you're going to go to your private room and complete that. And then the tech's going to ask you to change into your pajamas and go ahead and leave the door open or cracked open to know that you're done changing. And then when they come in, they're going to put electrodes on your scalp. They don't go in, they just lay on top with a small piece of tape, and that monitors your brain activity, so we can tell. We're like Santa Claus. We know when you've been sleeping and we know when you're awake. So we put those on for those. We put another topical monitor to monitor your snoring. It picks up vibration for snoring, and then you'll wear a cannula right by your nose that monitors your breathing patterns from your nose and your mouth. And then we put little fabric belts, comfortable little fabric belts that monitor your effort around your chest and your abdomen. And then we'll put some little electrodes on your rib cage to monitor the muscles in your diaphragm when they fire to try to breathe, but then that obstruction happens in your airway. Or are you not making the attempt to breathe? And that would be called central apnea. And that comes from your brainstem, a problem that we treat differently. And then we put some leg leads on. We put some monitors similar to like EKG patches on your legs. So when you move your legs or twitch your legs, that we can tell if that wakes you up, because we know what's going on. And everything that I just stated is time locked to a computer. So we get to see what happens first. So if your leg moves and then your awakening happens in your brain, then we know what caused what. If you snore and wiggled your leg, it's all time locked. So we know what caused what.
Fascinating. And then once somebody's study is complete, then you have a physician that is reading that report. Is that correct? And then provides recommendations?
Yes, the best thing about what I like about sleep is that there's so many sets of eyes looking at your study. So you have your tech that's there with you that night, and they're the acquisition tech, and they're going to make notes and observations, and they're going to give their impression of what they saw. And then you have another tech come in, and they're going to score the study. And they're going to look at every 30 seconds of every day, every time you're awake or sleep, and what's happening. And then they're going to put that into a report. Then the doctor gets all that information, and he looks at it again, and then he makes a conclusion and an interpretation. That's why I mentioned earlier, it's okay to just keep your PCP if you like them, and just say, I think I need a sleep study. My doctor will give recommendations to them, and they can continue to be your doctor.
Excellent. And if somebody does want to make an appointment, I do have the phone number up here. It is 520-324-3318. It does require a referral from any of your physicians. It doesn't have to be your PCP for a sleep study. Is that correct? And you guys are also following, of course, all the COVID-19 protocols right now, but you're still operating.
So I do get that question a lot, is what are you doing? So the best thing about TMC Sleep, especially now in our post-COVID time, is that the TMC Sleep Lab is located off campus. It is not anywhere near the hospital. I mean, it's across the street. So those compromised patients with COVID are in there. So we require a COVID test prior to your treatment study, where the risk of aerosolization of the virus, the CPAP mask that goes on your nose. So we test everybody and have them prove that they're negative, and then they can have their appointment. And if there was somebody that comes across that is COVID positive, that we would treat them in a different manner. We would not treat them at the lab, that we do the outpatients. So you rest assured that we're making every attempt to keep you and the staff and the other patients safe. And all the patients or all the staff wear PPE. They're wearing masks and gown, eye protection when they're setting you up. And like I said, it's a private room. It is a shared bathroom, but it's not. You will be there by yourself. And every time someone uses it, we disinfect it for the next person that walks in. And we've had good success with that. We've had no problems with on a COVID outbreak or anything like that.
Thank you.
We were able to continue to provide the service without having to be shut down.
Wonderful. So I want to thank you for being here today, David. This was great.
Can I make one other mention? I forgot to mention, a lot of the equipment that's on you is disposable. We did make that push about 3 years ago. So even prior to COVID. So it's not cleaned, disinfected, and reused. A lot of the equipment that we use is disposable. So it's never been on anybody.
Excellent. That's wonderful. Thank you so much. I really appreciate you being here with me today to discuss this important topic. I know we have a lot of viewers who are very interested in sleep, so we appreciate you being here. And we look forward to seeing everybody at our next presentation We do have a presentation coming up on Thursday, January 28th. And of course, our calendar is out for February, which is all about Heart Month. So be sure to check back in with us. We'll see you all soon.